and first and second line treatment. Please start your lecture.
Thank you very much. Konnichiwa. So where are we now for chemotherapy for mesothelioma in 2010? Well, cytotoxic drugs with single-agent activity, meaning a response rate of 25% or less, include pemetrexed, raltetrexed, and vinflunine. To prolong survival by 3 months or less, we can add pemetrexed or raltetrexed to cisplatin. To increase the response rate by 10 to 20%, we can add a platinum to pemetrexed, raltetrexed, irinotecan, vinorelbine, or gemcitabine. In preclinical models, many novel agents may seem promising, but few have activity in clinical trials. And several factors have hampered the development of effective chemotherapy regimens for mesothelioma. Meso is uncommon, so most clinical trials are small, and it is challenging to perform adequately powered randomized studies. Response assessment is difficult, the disease is hard to measure, and assessment criteria vary between trials. Meso is a heterogeneous disease with many prognostic factors and 3 pathologic subtypes that produce very different outcomes. Staging is unreliable. No staging system accurately selects non-surgical patients with similar prognoses. This table shows you the activity of selected drugs and drug classes in mesothelioma. In the old days, the gold standard drugs were the anthracyclines, specifically doxorubicin and epirubicin. But in 2010, the gold standard drugs are the antifolates, and specifically pemetrexed and raltetrexed. Antifolates get across the cell membrane principally by the reduced folate carrier, and pemetrexed may be more active in meso than in other tumors because the proton-coupled folate transporter is highly specific for pemetrexed and is upregulated in mesothelioma. In the past, we also thought that because the folate receptor alpha was highly activated, it also played a role, but recent data suggests that this is not the case. Now, as a single agent, pemetrexed is just as active or just as inactive as any other single agent, with a response rate of about 14% and a median survival of 11 months. But it was this single-blind randomized phase 3 trial of pemetrexed cisplatin versus cisplatin that put pemetrexed on the map and made this the benchmark regimen for mesothelioma treatment. Here you'll see a response rate that went from 17 to 41% with the combination, and improvement in median survival from 9.3 to 12.1 months. But pemetrexed doesn't only make people live longer, it also makes them feel better. It improves quality of life, it improves symptoms like dyspnea and pain, and it improves physical features such as vital capacity. But pemetrexed cisplatin is not the only antifolate combination supported by phase 3 data. This is a plot of the raltetrexed cisplatin combination, which also has shown activity in a smaller phase 3 trial. Now, although this is the benchmark regimen, there are a few things we don't know about pemetrexed and cisplatin, like when to stop it, what the optimal dose of folic acid is, what the role of predictive biomarkers, and when to give other drugs. So what is the optimal duration of treatment with pemetrexed? In the pivotal randomized study, patients received no more than 6 cycles of pemetrexed cisplatin. We know that in meso patients who progress after a non-pemetrexed regimen, second-line pemetrexed improves progression-free survival over best supportive care. A small non-randomized Dutch study showed that maintenance pemetrexed was feasible and responses can occur after 6 cycles. And of course, in lung cancer, we know that after a platinum regimen, maintenance pemetrexed improves progression-free survival. And these are the bases for a current randomized study going on in the CALGB and led by Arik Dudek, in which patients receive pemetrexed and cis or carboplatin and are randomized either to pemetrexed until progression or observation. Now, homocysteine is a sensitive marker of folate status, and a high baseline homocysteine level will predict for severe pemetrexed toxicities. Thus, in the pivotal study, after 1/3 of the patients enrolled all received vitamin supplementation, which decreased severe toxicity and improved response rates and survival. But we know that in preclinical models, as the extracellular folate level increases above physiologic range, the pemetrexed activity diminishes significantly, suggesting that we should supplement with folic acid, just not too much. What about biomarkers? Well, we know that in pemetrexed-treated meso patients, a low TS protein level is predictive of an improved time to progression and overall survival. Now, this is in a retrospective analysis from Giovanni Salvaggi's group and does require prospective evaluation, which is ongoing. But here you'll see a difference in time to progression of 19.9 months in those who had a low TS level versus 7.9 months in those whose TS level was elevated. TS was predictive, but not prognostic. Now, a marker by treatment interaction trial designed to test a predictive factor question, that is, testing for TS and then randomizing patients who test low to pemetrexed or gemcitabine and those who test high to the same regimens. This, unfortunately, is too large a study to be feasible in a rare disease like mesothelioma, requiring 1,700 patients or so per arm. So we're not going to be able to test it in a randomized fashion, which is unfortunate because gemcitabine cisplatin is in itself a very active regimen in meso, though there's significant heterogeneity between trials for a variety of reasons. And so the only data that we have comparing pemetrexed and gemcitabine-based regimens is again a retrospective series, this one from Chris Lee in Canada, which showed no difference in overall survival between gemcitabine or pemetrexed platinum doublets. So for your patient who can't tolerate pemetrexed, gemcitabine and a platinum may be a reasonable substitute. Now, what about special populations? Well, in countries such as mine, where workplace regulations against asbestos were instituted in the 1970s, meso has become a disease of the older patient. Our median age is 74 in the United States, and many of these patients have comorbidities and cannot tolerate cisplatin. In the palliative setting, carboplatin is frequently substituted with similar results. An international expanded access program demonstrated similar outcomes when pemetrexed was combined with cis or carboplatin, nearly identical time to progression and 1-year survival. And these data are supported by phase 2 trials of the regimen, which showed in a pooled analysis that elderly patients had no difference in outcome other than a slight increase in hematologic toxicity when they received pemetrexed and carboplatin. What about vinorelbine? This is also a very active drug as a single agent with a response rate of 24%, one of the highest of any single agent. When combined with a platinum, it doesn't appear to add very much. Now, the MSO1 trial, which I'm sure the next speaker will be talking more about, was a randomized study that compared active symptom control to chemotherapy with either MVP or vinorelbine. And when active symptom control was compared with chemotherapy, there was no statistically significant difference. But when it was broken down by the arms of the trial, you'll see that vinorelbine actually appeared to improve survival by about 2 months. Unfortunately, the benefit was not statistically significant, likely because the trial was underpowered because it was stopped early. So we can conclude that vinorelbine is likely offering a survival benefit, but we can't quite prove it. So what's next for frontline chemotherapy for mesothelioma? Well, this is a very partial list of new drugs that are being evaluated first line in mesothelioma, and I'm sure many of the speakers at this meeting will talk about other agents. And how should we be testing these new drugs? Should we still be performing single-arm phase 2 trials as so many other trials have done? Certainly, with limited patient resources, a single-arm phase 2 trial is attractive and practical, but given the heterogeneity of this disease, historical controls are not sufficiently reliable. So randomized phase 2 plus or minus new drug trials may be able to give a better signal of activity, as described in this editorial in the JCO. And we learned this from a trial that we had done of gemcitabine cisplatin plus or minus bevacizumab. The median overall survival in this study was quite long at 15 months, but when we looked at the two arms of the study, we saw absolutely no difference in survival, something we could not have determined from a single-arm trial. Thus, the new paradigm for frontline targeted agent drug development in meso appears to be randomized phase 2 trial of pemetrexed, cisplatin, plus or minus your new drug here. For example, the MAPS trial, which has just gone from a phase 2 to a phase 3, looks at pemetrexed, cisplatin, plus or minus bevacizumab, while the CBP 501 trial, which is a cyclin-dependent kinase inhibitor, looks at pemetrexed, cisplatin, with or without that agent. Here, the primary endpoint of 4-month PFS might be a bit short, but we'll have to see. One study that is not looking at a randomized trial design is the pemetrexed cisplatin MORAB 009 study, and they may have a difficulty interpreting their data because the key eligibility restriction is epithelial and biphasic only, obviously because mesothelin is not expressed in sarcomatoid tumors. So it may be difficult to interpret this selected patient data. So to summarize, for first-line chemotherapy, phase 3 data supports pemetrexed cisplatin as the worldwide standard. Pemetrexed and carboplatin is commonly substituted. Randomized data also supports raltetrexid and cisplatin. Retrospective data supports gemcitabine and aplatin. Underpowered data support vinorelbine, and most novel agent trials employ a pemetrexed cisplatin backbone, and a randomized trial design is preferred. What about second-line chemotherapy? Well, nearly all mesothelioma patients progress during or after first-line treatment. And most of these patients are still healthy at the time of disease progression and are thus able and often eager to receive further therapy. But the role of second-line treatment in mesothelioma is unproven, and the optimal regimen remains to be defined. In fact, the only second-line randomized phase 3 trial in mesothelioma was in pemetrexed-naive patients, which compared pemetrexed to best supportive care in previously treated patients. We see no difference in overall survival, likely due to crossover, but an improvement in the pemetrexed arm for progression-free survival and disease control, as well as the time to initiation of the next chemotherapy. So what about retreatment with a pemetrexed-based chemotherapy regimen? Well, this observational study, which is soon to be published by Giovanni Terrasoli in lung cancer, looked at 32 patients with the responding or stable disease lasting 3 months or greater after first-line pemetrexed-based chemotherapy. They were then retreated with this therapy second line. Interestingly, they had a 19% response rate, though only in the epithelial patients, and a disease control rate of 50%. You'll note that those patients who had a first-line progression-free survival of greater than 12 months had a significantly longer progression-free survival on retreatment than those who had a briefer first-line progression-free survival. And similar data were obtained with 1-year PFS and OS. Thus, pemetrexed-based chemotherapy should be considered second-line in patients who are achieving a durable disease control with first-line therapy. Now, what about the other second-line chemotherapy regimens for meso? Well, when you look at this table, you'll note that the survival observed of anywhere from 6 to 14 months is around the range of what you would see for frontline regimens, again suggesting this is a highly selected patient population. There was a retrospective analysis presented at this year's ASCO on second-line chemotherapy in 161 consecutive patients. They observed that second-line treatment offers a disease control rate of about 50 to 60%. a median overall survival of about 10 months and an almost 6-month progression-free survival. And the overall survival and progression-free survival benefit, not unexpectedly, appears greatest in the epithelial patients who respond to first-line treatment. This table summarizes two of the more widely used second-line studies, vinorelbine and vinorelbine with gemcitabine. Both of them have relatively low but real response rates and disease control rates of at least 50%. Overall survival, similar in both arms, but neutropenia can be problematic. Now, this is a partial list of the many new drugs that are being evaluated second-line in mesothelioma, perhaps an even better area for new drug development. Well, what is the optimal design of these trials? Well, given this very highly select patient population, I think single-arm trials are even more difficult to interpret, and really the randomized design is optimal. And patients should be stratified according to the outcome of first-line therapy, as well as to known prognostic factors. And time-related events, such as progression-free or overall survival, should be a primary endpoint. So some randomized options for second-line drug development, including randomizing to placebo versus your new drug here, or vinorelbine or another single agent, plus or minus your new drug here. So the phase 3 trial of SAHA that'll be presented later at this meeting looked at vorinostat versus placebo, whereas another novel agent, the NGRH-TNF, in a second-line study actually did not meet its primary endpoint or even meet its endpoint for going to the second stage of a Simon two-stage design, but they concluded based upon the median overall survival and the tolerability to move to a phase 3 trial. And here the control arm will be physician's choice of regimen since they felt that there was no international standard. So to summarize, for second-line chemotherapy for meso, in pemetrexed-naive patients, single-agent PEM is supported by phase 3 data. There's no standard approach for pemetrexed pre-treated patients. In selected cases with a prolonged response to first-line pemetrexed-based chemotherapy, retreatment with a PEM-based regimen should be considered. I think vinorelbine is a de facto second-line standard in many countries in the world. And given the heterogeneity of this highly select patient population, randomized designs are essential for evaluating new agents. With that, I'd like to thank you from the University of Chicago Mesothelioma Program. There are about 10 of us here at this meeting.